Okay, good morning. And Dr. Gopi and Dr. Mustafa, can you hear us and see us?
Good morning, sir. Very well. You're very
Very well.
clear. We are
Beautiful. So we welcome myself, my associate Dr. Keeney, and our fellows here, Janaro and uh, Rajiv, and rest of our cath lab staff. Very familiar faces, including Kiski on IVAS, imaging. We are ready to show this very interesting case. If we can just go to our presentation. So as you know that this is our in collaboration of Mediquest, Arun Gopi, the faculty, and Mohammad Mustafa as the moderator. Both are from Metromed International Interventional Cardiac Care Center in Calicut. Arun Gopi, actually both electrophysiologist and interventionalist. A lot of to his credit, new first in man done in India about various appendages and the pacemakers. Excellent teacher, and who have interacted with him quite a bit in the past. Dr. Mohammad Mustafa is a managing director and chief interventional cardiologist at Metromed, and very active interventionally. He's actually from Kasturba Medical College. As you know, Annu is also from Kasturba Medical College, and he completed his cardiology fellowship in DM in Madras Medical Mission, and very active interventionalist in various field of interventional cardiology and co-investigator of many trials. So with this is our goal today would be to show that left main bifurcation with imaging guided, whether some adjunct atherectomy is needed, and we'll do a two-stent approach always with question mini crush versus DK crush, and of course then you'll have a discussion on the two diverse complex case scenario. With that note, this is actually now start of third year with the Mediquest live series from Mount Sinai, case number 25. So basically, a 87-year-old, this patient had a known CAD and PCIs in the past, presented with angina a few weeks ago, and just went for cardiac cath because clearly the similar symptoms, didn't have any imaging test, and that revealed three vessel disease and left main at age of 87. Risk factors are shown there and quite symptomatic. SAQ score 33 means anything on towards zero side more symptoms, 100 is less symptoms, and patient had a PCI of the RC and LAD in the past, and the ejection fraction 35%. Good medical therapy, as you can see, multiple of them, and cardiac cath done, which revealed left main and three vessel disease. RCS seems to be more significant. Got two stents. Anu did a few weeks ago, and now comes in for this left main intervention. So Anu, you want to show the
Yeah.
picture? Good.
So
Okay.
this is EDP is 10. EF right here.
Right, actually much
Actually
better.
look
It is
normal.
read as
Close to normal.
35% by
Yeah.
the echo in the past. Yes.
Yeah. I mean, you see like
We did not do LV gram last time. Yeah.
anterolateral little hypo, but otherwise to me looks near normal.
Yeah.
So the stent itself looks okay, but the proximal part of the RCA, we gave nitro, still like a 50% is there, which we don't want to do anything at this time. So on the left system, if you see here in the caudal view, large circumflex, though the dominance is the right, ostial circumflex disease, you see it very well here. And this probably is a better one to show that. That you have distal left main probably about a 30-50, but then ostial LAD is also seen in certain views here. So this is the guide shot with nitro, where you see significant definite ostial circ disease, moderate ostial LAD disease. So our plan will be that we will wire both, and then we will do intravascular ultrasound of both stems, and then we can decide that if there is significant disease of LAD, we just will have to do double stent technique. If it is only of the left main to circ, maybe a single stent from left main to circumflex.
And actually, if you continue to play it, so looks like, there has been a stent in the LAD in the past, which is okay. But the proximal portion, angiographically, I will put it as a moderate calcium, not a severe calcium. The moderate calcium, because you see it in the cardiac silhouette during the cardiac cycle, and about 60% stenosis. The question is, if imaging, this is the kind of group which we say imaging should decide. Do you go more aggressive with atherectomy technique or just do a high pressure balloon dilatation or cutting balloon and so? So this is what we will do, IVUS, and then based on that, as mentioned, that we use a 2-stent versus 1-stent approach. But clearly, you see about there is a 50-60% LAD. So once you have that much and you have a stent in the, you put a stent in the left main to circumflex, that is likely to pinch. And we always tell everybody that if there is an obstructive disease of the side branch or the left main, whether the concept of 1-stent versus 2-stent, I know EBC1, they wanted a stepwise conventional 1-stent approach, but we always have believed that stents is better rather than you end up in putting a bailout, whether you do a later on cool-out or tap technique. So with that note, I'll ask both Arun and Mustafa, tell us what would you do in this particular case, and we'll give you the data on the IVUS. Anu has wired the LED.
No, I wired both LED and circumflex.
And going to do IVUS of the LED first or circ first?
Circ first.
Circ first. Okay.
And then
With
we'll
that
go
note,
to
while we can I complete my presentation quickly, go back, because we always want to show our appropriate criteria. This basically is a left main and 2 to 3 vessel disease. This patient had a heart team discussion with high syntax score and diabetic. So it's still appropriate, although it's maybe appropriate, but definitely A after the discussion. Okay. All right. We're ready with the IVUS.
Yeah, we're going up with IVUS.
Okay. Show that IVUS on the main screen now, and continue to show hemodynamics on the left bottom, because seems to be some ostial left main disease because there was ventricularization.
Your angiomax are happening.
Yeah.
So angiomax, our ACT is 335. She has been on Plavix with a PRU of 200.
He or she.
So usual cutoff for
She,
PRU
right?
is 230. So come
It's a
closer.
he or she.
So we're going into the.
She. Why
Okay.
she
See,
is
I'm having.
Yeah, no, it's not close.
Okay.
Okay.
Thank you so much.
Okay. You're doing on the circ first. Okay.
Yeah, the
Good.
circ first, but
Yeah.
you see there was some resistance in going.
So guide out, right? Guide out.
Yeah, yeah.
Thank you.
Okay.
Okay, start for back.
Proc circ.
Yeah, block suck. Yeah, good landing zone. It's coming. Yeah, no, almost no plaque here. Big vessel, like more than 4. Coming to the ostium.
Look at the floor also.
Yeah, so tight, but not
Yeah.
so much calcium.
Is
I've
the-
come to the left main. It's a body of the left main. Yeah, here,
Okay.
the blocks left main is tight.
Okay.
And come to the
good.
guide.
Continue to show a little bit of cine of the flora also when we are doing the IVUS, so that everybody sees which way we are going. And now we are going after the LAD. So basically we saw that ostial left main, non-calcific, correct?
Ostial,
Ostial
left main
circumflex,
has circumflex,
non-left.
not so much calcium.
Yeah,
but
calcium is less than 1 quadrant.
Yeah, circ.
So that by definition, remember IVUS definition is more than 2 quadrants, and then it goes with the length of the lesion. If you're 3 quadrant and more than 10 millimeter, it will be severe. 2 quadrant, less than 10 millimeter will be moderate, and rest is mild.
Dr. Sharma, the proximal left main is also tight, like area is 4.7.
Left main is also involved. So distal left main, as we saw angiographically, confirmed by the IVUS. More important here is the proximal LAD, which looks somewhat calcified, not a severe calcified in terms of our strategy. Nowadays, we actually have a large vessel. Proximal lesion could be even done with IVL. Doesn't need to be atherectomy, all these cases, even if there is a circular calcium.
So we are going into the LED now. This is where we are.
Yeah.
Okay, kiss key.
Yeah,
Good.
sure. Check the image. Yeah. Yeah, start forward. Yeah, like
Put IVUS on the main screen now.
yeah, concentric plaque. Yeah, a lot of calcium here, like
Yeah.
almost 360 calcium.
360. Wow.
Yeah, but lumen is like okay. It's coming to the proximal LAD.
Flora, where are you?
Here is not so much calcium.
Yeah.
Looks like
It's
still
there, it's there.
intra-stent or the
So
stent.
it's more. It's a stent.
Yeah. And come to the left main.
Mm.
Yeah, distal left main is okay, but the proximal left main is tight.
That's why it was damped. Okay. With that note, we need your opinion of
Go back to the ostial LAD.
Shit.
what will be your approach with angiogram, which we have shown, and the imaging which had been shown. Basically, interpretation of imaging is calcium, circular calcium in the proximal LAD, but not that much tight, lumen wise, but there is a circular calcium. There is a significant lesion of the ostial circumflex and ostial left main. The left main is less than 4. And that is why the ventricularization, look at the hemodynamics. As soon as you put a catheter ventricularization, it tells us that there was a left main disease.
So
Yeah.
that's LAD.
Yeah, osteal LAD is
LAD.
like around 4. So, and here it also looks like the outside stent and concentric neo intima, so it's ISR, but not sticking to the left main. Yeah, LAD has a diffuse like ISR.
I guess we could just do with balloon and cutting balloon. You don't need IVL.
Okay.
Yeah, no,
All right. So Arun, would you do IVL in this case? In that for the LED segment with the circular calcium, although lumen is about a good size lumen, just 4 millimeters square, 60% angiographically. We know that once you put a stent in the left main to the circumflex, it will get into trouble. So prospectively go with the take care of that with the lesion preparation, or what will be your approach? Good. Keep doing. No.
Yeah. So we'll cut it, SS.
A warm good morning, good evening from India.
Yes.
At the outset, I thank this opportunity to learn from the best
3550,
interventional
high pressure.
cardiologists in the world and the best team. For us, it's a great learning opportunity, and it's a great case. Actually, what my thoughts are on, it's mostly a disease which is concentrated on the osteoproximal left main and the osteoproximal circ. The luminal areas in the LAD is good, although there is calcium, but there are good lumen there. So my take on this would be to have, after adequate lesion preparation, stent from LM to LCX, rewire the LAD, then probably physiologically assess the flow into the have an FFR assessment of LAD after we have opened up the struts towards LAD. And if you require an intervention, probably a cutting balloon on the LAD followed by a drug-coated balloon if we can get out without a dissection, without having a stent placed in the LAD.
Very good point. So only question is, we don't have drug-coated balloon in United States yet.
Okay, go.
We are just starting some trials, more so for ISR, but drug-coated balloon is not available. So that's a very good
16,
thought,
18,
and that is what
20.
happening now in many places, particularly in the long diffuse. Rather than putting a multiple stents, you do a drug-coated balloon, an area which has not expanded well with the balloon. That area only you would do a DES.
375.
Yeah. So this
Wolverine.
is, now you see this here, ostial circ did not open up with this. What balloon is it?
It's a 3.5 high pressure balloon. We went up to 20.
Yeah, Wolverine.
Yeah.
Hello,
Yeah,
hello,
yeah.
good evening, sir. This is Dr. Mustafa just joined. I'm sorry,
Yes.
I was a bit late to join. Yeah, I was in the journey actually. I just
Sure.
attended the Gulf PCR and on the way back to
375.
Calicut. So yeah.
Perfect. All right, Mustafa, welcome. And this is what
Yeah,
just
thank you,
case of
thank
the
you.
distal left main bifurcation. And
Yeah, I was
we
just watching that. Yeah,
oh,
I was
good,
just
beautiful.
watching that. Yeah.
So as you saw,
So
that
yeah, I have a question, sir. When you have a very circumferential calcium, it's a very tough thing. Like, I mean, you have 360-degree calcium. So
Yeah.
in such situation, should we just start with the rota first, or what will be your strategy
Yeah.
to start with?
very good point. So question comes down that based on the lesion obstruction, remember the lumen is just about 4, 3.95 or 96. So question is, we can use rota, which will be okay. We can use 2 bar because 7 French guide, or in these cases, what I tell nowadays, less traumatic will be using IVL. IVL is very effective, although cost
Yeah,
is prohibitive. The cost is 3 times more than rotational atherectomy. But IVL is a right up. This case, I would say, will be better for the IVL rather than rotational atherectomy. So that will be my recommendation. So now we are going with the 3 still we are doing a 3 the circumflex ostium, which you saw non-calcified. I mean, calcium was less than 90 degree arc, and now after balloon dilatation, even this is a 3.756 millimeter Wolverine is
Now,
not going.
Okay,
the
fine.
ostium of the circumflex did not have calcium.
No.
I'll
Yep.
go back. Yeah.
Yeah,
Okay,
good.
go.
That's
Yeah.
good.
Okay, good.
So now it went in.
Since
Always.
you saw, even with IVUS, I had difficulty in getting the IVUS into the circumflex. That's why we went with the, just a high pressure balloon first. Okay. Go
Yeah.
back to the circ ostium.
Sure.
Why we see that circular? Okay, go up here. How are you went?
Now you have to pull back and go high pressure.
I
And
did.
remember, all these cutting balloons, scoring balloons, you can always go 18 to
18.
20 atmosphere.
18.
Not an issue. Now, open NC balloon, just available in United States, and we'll be using it in next of our live cases, but just made available in USA, just approved. But we still don't have a drug-coated balloon out of the trials. Only trial of the ISR have started. There are some other programs going
here.
also for the native
Wait,
vessel
wait.
side branches,
left
but
main.
we are part of the the ISR trial. So we actually, for the multi-layer stent,
Now it's opened up.
restenosis, we actually very good in IVBT. We have published the data of the brachytherapy, which decrease your MACE rate from 50% to 18%. We are now doing a long-term follow-up of those patients, 3 year and so, so hopefully soon we'll publish that part also. Wow, Circ opened up very nicely with a cutting balloon. So now question is, look at the plaque shift. See that LED? Now became quite significant. I can guarantee you do IVUS now, your lumen will be less than 3. So this is what we always say. Once there is some disease, so it's probably better off. So Arun, would you change your plan now? Or you still want to keep the same and then do the kissing and then knowing that there is no drug-coated balloon? So just with that caveat that there is no drug-coated balloon, and likely you will end up in putting a stent in the ostial LED, because unlikely this will open up nicely. Just alone there was that lesion, borderline lumen of just 4 millimeter square, and now there is a significant plaque shift, maybe a little dissection even, which has gone open, which is okay. We want to have create dissection with our technique so that the lesion will expand,
LED.
and that's where we are now.
Cutting balloon.
Same.
We'll use the same cutter for the LED.
Yeah.
Now going back, I know a lot of discussion. This is you're showing the IVUS. Show the IVUS back there. This is the ostial LED.
Yep. The concentric neointimal in the
So there
old
is
stent.
intimal hyperplasia.
Yep. And the calcified part is very
Yeah, I
partial.
think,
Like, a little bit mid part is like 360 calcium, but not super tight.
It's best we go with the two-stent strategy, right?
Yeah. I mean, based on that, because
have-
remember, there are a lot of people, stepwise, conventional,
Cutter.
approach versus two. We actually, when we had the bifurcate, even back then for the left main, before even the data of the DK crush came, when we said that once it is distal left main bifurcation, which is 100, or both, which is a 111 or 011, those cases prospectively go with the two-stent approach. And I think
80.
even with the EBC1, data has not shown one versus other is better. We fully believe that it's better to go prospectively with a planned two-stent approach rather than do a bailout second stent approach. Then of course it's a part of the discussion, and we ask our the chat viewers also if they can put a question in the chat. Yeah.
Okay, good. Down.
Yeah. So, sir, have you done an IVUS run after seeing the plaque shift into the LED ostium?
No, we have not repeated it. I mean, I know you want to answer that.
Fine,
Yeah.
fine.
Yeah, we did not repeat it.
Angiographically, but you saw that angiographically became significant.
It looks significant.
And this is when we
now
are given the
your strategy
nitro.
is to go for a,
Two-stent.
yeah,
Yeah.
okay, fine.
Now, going back to
Two-stent
your going back to the question why we did not do IVUS run, so you can see that it was borderline 3.9 to begin with, cross-sectional area with intimal hyperplasia, and once you angiographically you see it, we felt no need to do another imaging run.
Tell two-step.
Yeah, suppose in another case, suppose in another case, if the LED ostium to begin with is insignificant, and after doing this, plaque shift, would you still consider double this thing, or after looking at the IVUS, you make a decision?
Okay, so going back to interesting question, that there is distal left main to ostial circ, and ostial LED is just 30%. So we do, a different case I'm saying. So you do a cutting balloon or a PTCA of the left main to circ, and at that time if you have plaque shift, right? So you can do IVUS and then figure out what is your cross-sectional area. So if it's just a plaque shift, or we also call as carinal shift. Yeah.
Yeah, correct. If it is only a plaque shift, then still we may not, even though angiographically it looks significant, still we may not consider a second stent. We may finish with one stent. That should be your. But I think that will be your.
Yeah, one stent is good from left main to circ,
Yeah.
but you may want to, pre-dilate the ostial LED before, and if there is a plaque shift after stenting. I'm saying so many times
Okay.
it may look
Okay.
good after stenting. You will be plaque shift or canal shift. If you see that, you may want to recross, and at that time you do pot followed by kissing. Yeah.
Okay. I
And
mean,
any
even then, you will do only kissing only. No, not you may not consider stent even then.
No, you'll do a kissing balloon, and after doing a kissing balloon, if
Okay,
it looks
fine.
good, we are done.
Yeah.
But now
Fine.
a lot of
Okay,
people
fine.
will probably tell, okay, put FFR wire down.
Yeah.
We usually do not. We will go with the angiographic finding. If it looks good, we are done. If we think it's questionable, now that you already have a stent from left main to circ, you'll have to do a tap technique, or people would love to do culotte. We are not a fan of culotte because you will have unnecessary 2 layers of stent in the left main.
In the left main, correct. Yeah. Okay.
Okay, so now we are stage is set for the two-stent approach, and as I said, that let's ask if any of those questions of our audience asking in the chat box. So we are putting two stents. And know what stent you want to do.
I mean, we can put
4O?
Promus, right?
Yeah, 4016 goes from the circ is the main vessel in this case, right?
Okay, so 4O is good, Kiski?
Yeah, actually, vessel
Okay.
size is like average 4.5.
That's okay. We do 4O, and then we will do
Yeah,
proximal optimization
Yeah.
with
Yeah.
4.5.
Yeah.
So we get a 4O16 to the left main.
And LED?
Yeah, so-
LED short, right?
yeah, it is like actually diffuse like neo-intima, not super healthy landing zone. But it looks like all in stance. So the vessel size is 3.8. Maybe we can put a 3.5.
3.5 16.
Yeah.
3.5 16. So we are putting a 2 Promus. This is the 4O.
So give me so always go to the side branch first. The side branch here will be LED. So we'll go with the 3.5 16 to the LED.
So do we have an angio after the opening up the ostium of LED?
Oh, yeah. Let's
we
take a
can do
picture,
it.
yeah.
We'll do it.
Let's do the picture. Yes, you're right. Let's see it.
Good.
Pull both the wires back. Yeah. Yep.
Looks good.
Now there is a plaque shift into the circ, which is okay. We know that we have opened the lesion. Yeah. We have opened the lesion of the
The
circ.
lesion is
That's the key.
open. The lesion is open. We don't have a flow limiting dissection in ostium of LED. Would you still consider a 2-stent strategy or still an LM to LCXL?
Very, very good point. So I think the decision to go with the LED was even pre-imaging, and on the angio about 60%. Then when we did the imaging, it confirmed it. The lumen was just 3.9 or so. So we felt that yes, whether there is a plaque shift or not, we'll go with the 2-stent approach.
Yeah, but if somebody at this time wants to just stent from left main to circumflex, that's acceptable.
Yeah.
That you want to do, that you did a good, PTCA, like you said, you want to do drug coated. Yeah.
Yeah, even
And,
I was just thinking, why don't we just do stenting from left main to circumflex and then observe the LED ostium again angiographically. And if we have any doubt further, probably we can do an IVUS and then take a final call on that.
No, but
Deciding
remember,
about the second-
no, that's a very good point. But I would say that there was a decreased lumen to begin with, and we know that if there was although we didn't do the FFR, but with the left main, it's always difficult to interpret that. So we all knew that
LED.
before we went into that path, that journey, that LED required intervention by itself. Why? Because of the angiographically 60%, and there was on IVUS it confirmed it. But you're right. So question comes in, now you say, well, only way I would say that you want to just do your strategy if you have a drug coated balloon, because we know with a PTCA alone or cutting balloon, you'll have a high restenosis of that LED. You don't want this patient to come back again with a 20% chance of restenosis, because we know with the DES, you'll bring that number down to 5%.
Sir,
That's the
can you
reason.
take a
Probably.
Can you take a decision of proximal LED based on the lumen alone? LMCA is fine, sir. Do we have the evidence to take a decision to intervene on the proximal LED based on the lumen alone in the absence of physiology?
Well, I mean, remember most of the data when they have combined the IVUS lumen of the 4 millimeter. Actually, the favor trial, which looked into the OCT, I mean the IVUS versus FFR guided. showed no difference. And FFR, of course, we have 0.8. On the IVUS, they had the lumen of less than 4 millimeters square, or sorry, less than 3 millimeters square, or 3 to 4 with a plaque burden more than 70%. So that is basically the favor trial published in NEJM, and showed that strategy was equal. But yes, means on the imaging alone, what are the criteria? Criteria basically is either less than 3 millimeters square lumen, or it is 3 to 4, but plaque area is high, more than 70%.
Can you put bifurcate by the side?
Yeah. So this is where the strategy was. So yes, lumen, the question is, what class 1 indication has become is the imaging. I mean, so with the physiological testing, not the imaging. Imaging still remain the decision making in the 2A and 2B criteria. But FFR, IFR has become class 1 to make a decision. Lumen decision is not class 1, but the trials have answered that question, that do you do based on the IVUS criteria or based on the FFR criteria, is there a differential outcome? And answer to this major trial published in NEJM called Favor did not show any difference. Okay, now let's see what you are doing now, and tell us.
So we have the side branch. We are making LED as a side branch, okay?
Yeah.
And then the left main to circ stent is already sitting as a main branch.
No, but your stent has to come back to the ostium, because it has to go all the way out.
No, yeah,
because then will be tough to move. When you really have little crush of the stent, to move the stent will be difficult.
We had it up to the ostium.
Yeah, good. Yeah, this looks good.
So we should also
Okay,
like to
show some
thank you
die.
for all the wonderful apps that you provide. Actually, they are very useful and handy.
Okay, good. No,
Great
you
job.
see that left main,
Yeah.
I think we are sticking out too much.
Yeah, 1 millimeter going. Yeah.
No. Yeah. So
No, but
what-
that's okay, because stent in the promus is inside the dot. Yeah, that will
yeah,
be
but
okay.
we may have to go to cranial view to
No, this is
fix
okay.
it at
This
the
looks
end.
very good
Okay,
here.
some die. Yeah. Yeah, we are good there. Okay, go up with the LAD first. So side branch first. Go.
So could you check the protrusion in two views, sir?
Yes, it's a millimeter protruding into the left vein. You see that? See that stent sticking out a millimeter. Good. Down. Go up again. 12, 14. So after this, what I'm going to do is remove that stent balloon, STS, down. We have to remove the wire also.
And 3.5.
Gentle
12.
here, yes. Some dye to confirm that we are okay. Good. You want to go cranial to check?
As long as you are fully covered, otherwise you can pull it. Yeah. No? Okay.
Do you think at this moment, while you're pulling the balloon out, is there a point of flaring the LED ostial stent?
Yeah, that's a good point. So, love people, the key is that same balloon pull back and go high pressure 2024. We do modified. I do it.
Yeah, not me.
But not doesn't do. But I do that. Yes.
Yeah, I know, I'm watching.
Would we be looking for the distal dissection before?
No.
getting the wire out?
I'm trying to make sure ostial left main is fully covered. Patient had disease up to the
Dr.
ostial left
Chini,
main. Yes.
Yeah, in this case, what factor made you to decide that LAD is a side branch and LCX is a main branch? Is it because LCX is dominant or because
Size.
LCX lesion was more?
No, size.
Size.
Remember, Medina classification
Size,
is
okay.
based on the size. Yeah, purely size.
Not Medina.
Yeah.
I mean,
Okay.
on,
Medina,
the
Medina.
syntax
No,
also.
but I'm
Yeah.
saying all the textbooks are Medina. The main branch is your big size. Size-wise, you're right.
This one,
This
go
is
up.
not even a left dominance,
Okay.
Go up.
but circ was big. So when we
Okay.
call our side branch, so LED side branch because of that. Yes.
No, that's one reason.
Okay.
And number other thing also, remember, already there's a stent in the LAD and we're already having a discussion down that why don't we just
correct.
stent left main to circ and leave the LAD alone only from left main to circ. So in that situation, that's what, but the size definitely it goes bigger. Go up again.
Pull back. This one you can do flare.
Yeah,
Pull back
this
and go
one we
very high
can flare.
pressure.
Yeah. Yeah, good. Down.
Let it pull back
So I'm
and
going
then
to
go
pull back.
Usually do a 16 atmosphere. Now pull back and go
Okay, go up here. Yeah.
20, 24. Yeah. Your guide is going in. Always will happen. You pull back the balloon, guide sucks in.
Okay, down.
And this one will require pot. We know the left main is 4.5. So we have the
8
4.5, 8
millimeter,
millimeter
458
balloon. Yeah.
millimeter.
Yeah.
Now
You want-
again, the other questionable. Oh, okay, forget
Take a
it.
picture and go to caudal view again. That's better.
Again, another questionable discussion will be is that recross before or after. We always say, left to the
After.
discretion of the operator.
After the pot would be the ideal time to recross.
Your wire.
No, that is a fielder. I may need another wire to the. Get me
Okay.
a different wire for the.
Yeah.
It's all gone.
Good.
Madam, what
Let's
are
take
your
a picture.
strategies to prevent guide-induced the ostial stent distortion after you have protruded?
No, you just have to be very cautious with how the guide is, extending in.
And more
You saw
important,
how I went in with the guide, yeah. Especially if there is ostial coverage, yes, there will be LSD. Risk of LSD is there with no matter what kind of stent design you use, yeah.
but key is that what I
That you have
always
to be
say.
very, very careful. Number one, and then most of our guides, we use mostly the Boston Mark guides. The tip are very soft. Okay, ready?
But key is that advancing your guide on the ostium on the balloon.
Yes.
So that it remains in the lumen, in the center. It does not enfold the ostial stent. So that's one way to prevent it. And of course, otherwise a softer guide, a stiffer guide will destroy it.
Give me a fielder.
Okay, so now that's okay. Now we have to recross
Yeah, recross.
and let's discuss what you see on the angiogram.
Sir, do you do a pot
Do a
before
picture here.
recross?
Yeah, that's a good point. So I think it's a matter of okay, go take the picture. Yeah. So question comes down to here. We did knowing is straightforward. So it is we can do a pot first and then do it. But key is that you still have to do when you have gone to the side branch dilatation. You still have to do a kissing balloon. So this case is straightforward. Our approach will be go into the wire into the LED now, open the ostium of the LED with the 3.5 balloon, that's where the size was, and then put a 4.5 balloon which will be the pot. So what you do is first you do a kissing balloon of both 3.5 in the LED and 4.5 in the ostial circ, moderate pressure on the ostial circ, and then take the LED balloon out and then bring back the circumflex which will be the pot and approximately go 20 atmosphere. So this is one way. Otherwise, with the pot, and then even if you do a pot now and then you do kissing, a lot of people then do a repot and so. But I think we'll be okay to do the one. Even if you have done the pot, we'll just do the kissing balloon and we'll end. We usually do not go and do the repot, but kissing balloon, yes.
Sir, what are your strategies to go for the selection of the struts to cross or the cells to cross?
Yeah, so very good point. I always say, be happy wherever you go through.
Yeah.
So as long as it's not just in the very proximal part, although with the DK crust, they say earlier is the better, but here that you want to go kind of a middle. Don't have to worry about distal and so middle is okay. So right now we have done it's 3.5 balloon now. And you want to do a pot first or you want to do a kissing? Yeah.
So it's in the center,
Yeah.
right?
Good. It's in the center now.
Let's do pot followed by kiss and out.
Okay. Let's do the pot. Okay.
And
So
the question is the same.
yeah.
What we call is adequate recrossing, optimal recrossing, whatever. We got to be happy that we recrossed at the right strut. So if you see here, can you see on the cine that looks like it's in the center?
Yeah. Yes.
Yes.
Going in the center, I think that is okay. So question comes down to what I will avoid that maybe just go to the first strut because that will become a very little, you'll not be able to open the ostium well. So question, once you have gone to the middle,
truly,
that's okay.
How are we going to decide on that on fluoro?
Yeah. No, it's in the same of the vessel, same segment of the vessel. You go into the, try to aim for the middle. That's why we are saying, whether you're DK crush or mini crush, aim for the middle part of the side branch stent. Whether you go little with this cell versus that cell, to me, I think it's a matter of semantics. This has been a lot on the data we got from Olmistran on the, those test tube issue, but I don't think that clinically, in my opinion, makes any difference.
4.5.
Okay, this is the 4.58.
Yeah. enough.
Just one elementary question. We have a calcified bifurcation. Would you have preferred an OCT over a IVUS for assessment of calcium better and the bifurcation better?
I mean, if it's distal left main and you have left main is long, of course you can do OCT. And the question is yes, yeah, I think it's a better. Oh,
I mean, there's no question about that OCT will be better in terms of calcific quantification of calcium and so. So that is for sure. But only problem is it's not good for the ostial left main. The OCT, the data are clearly that ostial left main is not good for OCT. And secondly, sometime in the large vessel and you have to do multiple runs and multiple injection of the
LED.
dyes and so. But yes, both can be done in this particular case.
3.5.
Quantification, better stent of position, all those are much better with the OCT compared to IVUS. But we decided, actually, you are a very important point. We did talk about it. What do you use, OCT or IVUS in this particular case? I said there's no reason to do both, and we decided IVUS. But yes, OCT could be used also because patient creatinine is just about 1.1.
Yeah. Probably the hybrid catheters in the future with both would be best one.
That is correct, yes. So this is a 3.512 going into the LAD, and we actually have done the pot already.
Yeah, even then it's not going. We may need a
2 or 12. What
yeah, 2 or 12.
So for the sake of discussion, like, is there any specific reason for doing pot before the kissing? See, the reason what I have is like to avoid the wire going through the, between the strut and the vessel wall. We, usually pot and then recross. Is there any other reason like to do pot before recrossing?
Yeah. So question was that we recross and then we did the pot. Question is that do you do a pot first and then recross so that you try to get to a better inside the lumen? But I said the answer to that is very simple, that you try to go a little further and one of the big way could be you change the wires. Put back your circ wire, go into the LED, and then put a new wire into the circ. So that will guarantee from that point of view. But yes, I think this is a lot of variation. And to me, the strategy, knowing that we have the biggest international program with the 8 fellows, we try to teach them do the same way all the time. So if your wire has gone in, that's okay. If the wire has not gone in, then you definitely have to do a pot before. And so I think this is now, once you have that difficulty, you try to recross. So let's try to recross. Maybe you really went into some different
do we recross or do we do anchor? That's my only thing.
No, I think first do recross. Otherwise, we can do anchor also. They have if you cannot do, so we will show on the bifurcate 3D with the anchor. But I think try to rewire it. Always rewiring definitely helpful because you have done the pot now.
Not
just rewire.
You have to remember there's 2 layers of
No, I know, but let's get rewire once again. Yeah.
In a short LMC, when you want to re-exchange the wires, when you take out the circ without a pot, would it be safe, the circ wire coming out?
Oh yeah, knowing that you're taken the good angiogram and your vessels are nicely open, then there's no issue at all. It's still giving a difficulty. And this is a 2 or 12 compliant balloon. Right?
No. Okay, get us, let's try anchor.
It's the same balloon?
No, this is 2 balloon.
Yeah.
So get us.
But compliant or non-compliant?
No, you need, it's a big vessel, right?
Okay, use the anchor then, fine. You
have
put a 3.5?
We never have 4.0, right? 3.5. We had a 3.5. Get the 3.5. Yeah, 3.5 is here.
No, but 3.15 will be too long for the circ. 12. Okay.
Otherwise, have the 1.2 balloon ready, Pablo. Yes.
But that's surprised. We have done the pot and we have recrossed it and still in this large vessel because of the double layer.
Double layer, yeah. Because the reason in the early part, remember I was having the difficulty even in I was going, that means one strut was sticking in the left main. So we crushed, that's one layer of strut, and then we crushed the LED stent. So it's essentially 3 layers. So
maybe you would require a smaller balloon to start with.
Yeah, we did a
We
2
We
0.
did.
five.
Yeah,
That's a
2
2-0.
Yeah,
We
no,
did. We tried 2-0, but before I to go to one smaller than that, I want to try anchor technique. If anchor technique does not work, then we will go 1.2. We have it ready.
1.5.
Yeah.
Yeah.
The
Yeah.
smallest balloon we have is 1.0, but I think 2 maybe.
and in India they actually have 0.75 also.
Okay.
Yeah, Nick Nano, we have
Yeah,
0.85.
0.8. Yeah,
But since it's a large vessel,
good.
I mean left main
Gentle,
bifurcation, I
gentle,
think two
because
should
we are
go.
outside the
Yeah, no,
stand. So we are outside the stand, so we will
there's
go
low pressure.
little
Yeah,
low
good.
pressure. Yeah.
Yeah,
Good.
Okay.
Keep holding
the
it.
little anchor, and now we are going into.
No, it may not allow it. Okay, down, down. There's not enough space for
I
it to
think
go.
open the ostium a little more with this balloon, high
Of
pressure.
LED. I
Yeah,
mean,
the ostial circ with this balloon, go to very high pressure. Yeah, here.
go up.
Yeah, right. 3.5, go 20 plus.
Okay,
Yeah,
down.
and now try. So part of that could be the struts are not full.
Okay,
So
now
would the
here
amount of
low pressure.
protruded crush stent be giving all the difficulty?
Yes. Wow, this is the 2-0 which is recrossed after the. Uh,
Okay, down. Right. Okay, 1 point.
okay, so
We go
okay 1.25.
there. Ready.
Does
So
this difficulty give DK crush the advantage over mini crush?
yeah,
No,
so
you can see we have done so many live cases with the showing a mini crush technique. This is only because we have 3 layers of stand there in the LED now.
yeah.
Okay,
Okay,
man.
down.
Yeah, so that was one of the reason. Yeah, so that question always comes, the recrossing, and more importantly, actually the ostium of the side branch with a DK crushed lumen little better. Anecdotally, there is no randomized trial. The ostial side branch lumen is better in the DK crush compared to mini crush because you have opened the ostium first.
1 point
No, but this is again fielder wire. No, go with the run through.
to the LED.
Yeah, go with the run through because you have
Wait a
both
minute.
fielders wire. Yeah, that's destroyed. Give
No,
us
no, that's one thing. Another thing also, the body yes, of the fielder probably is
soft.
softer now.
Give, so we are going to recross now. Where is the
We'll
run through?
change
We
a
have-
different wire
yeah.
also.
Yeah.
We have a run through. Oh, there was no run through there.
Would taking a microcatheter along
Yeah.
with for
No,
support
that
and
we
extending
talked
the
about it. Yeah.
support
So
by
the other one could
taking
be that you can use a Corsair. Corsair will go through the struts, but I think I mean I still little uh, cannot really explain the difficulty we are having. Particularly, we have such a nice here, but you can see the jumbled up stent layers at the ostium.
yeah, yeah, the protruded stent crushed
Yeah.
stents which are giving us a lot of trouble.
Yeah. So we go with a 1.5, 1.2. So we are going with a 1.25 balloon. Uh, or you want to go 1.0? No, 1.25 is okay. Yeah. Good.
Wires are out.
Huh?
No, he's saying there are PVCs. He's worried the wire is in a small branch.
Yeah. No, the other one is slightly. So we'll pull back a little
No,
bit.
no, no. I
Yeah,
I
good.
advanced it. It was
Yeah.
behind.
Good.
Okay, now
Yeah.
this is the third time we crossed. Okay, various struts. Yeah.
Good. Okay. Go.
Let us see. 1.2. If that does not go, we go with the Corsair.
Yeah. So same, the Arun, what you said, that you do also the flare the ostium of the side branch
Yes.
crushed while coming out. This does it facilitate this rewiring and reballooning? I mean, crossing the balloon after that. It's kind again anecdotal. I do it, and again, is there a scientific basis for it? It's just basically the ostium you're trying to open a little more. We all know that crush is always a trouble. Which you go. Okay, now let's see the balloon.
Yeah, went.
Yeah, it went in.
You guys saw it? It went.
Yeah,
Yes,
Go.
yes, ma'am. Yes.
Good. Go up.
Yeah. Yeah.
yeah. Now go with
So
the.
now we will go 20 atmospheres, make a little hole there,
Slow.
small hole. And now give me that 2-0, I guess, right? We have
Yeah,
to go
2-0
gentle.
first, yeah.
Yeah, down.
Good. Yeah. Here.
Yeah, go up here.
Go at
The
this level, yeah.
ostium, yeah. Okay, there. Yeah, go up.
So this is a
This question might be-
1.258.
Yeah,
6
these
millimeter.
pressures might be above the above the rated burst pressures, right, madam? So
Yeah,
is it
100%
something
above rated, and sometimes we want to burst it actually.
yeah,
Down.
granuloplastic?
Good.
Yeah,
Want
yeah,
to-
yeah. Don't tell the fellows; they
Yeah,
like
yeah.
to burst it. Yeah, they're waiting to go full circle.
Good.
Okay, now this is good, and now I go with the 2O.
Yeah, we already have a 2O balloon. This was a 1.25, 6 millimeter.
So two things we change. One, we change the wire also. We went with a run-through wire. But again, the question comes, is run-through a good wire to go through all these multiple layers of strands? It's not. We
I
usually
think
like a
probably a fielder,
polymer.
fielder
Yeah,
would have, yeah.
yeah. So
No,
first I
earlier
tried
was
fielder.
Usually
fielder.
my preference is fielder.
Yeah.
Yeah.
No, earlier all those balloons were tried on fielder. We had a fielders. Yeah.
Initial was fielder.
All
We tried
fielder.
fielder. And always we say, if you want a side branch, always go with the fielder in the side branch.
Yeah.
Recrossing strand studs are easier with the hydrophilic polymer jacketed wires. But here the body was probably not giving enough support
Right.
of the fielder. That's why we changed the wire. And now let's try with the 2O.
Or maybe it's just we went with a very small balloon. I mean, that's now. Okay.
Yeah, when you two
Yeah.
multiple
Sir and madam,
permutation
with all your
combination.
yeah.
Okay, good.
With all
We
your
crossed.
voluminous experience, what do you think is the different other strategies other than anchor if you are difficulty recrossing? Because this is the Achilles heel for mini crush where we find recrossing balloon into the crush stem. So, what are the other options other than using the anchor?
Down. Other options. So you saw us. If our anchor did not work, then we went with small. So let me tell you if the wire does not go. First thing you do is that we've done the pot. You will try, recrossing through multiple struts. Anchor still did not go. Then you go with the smaller balloons. Okay, and it still did not work. Like suppose 1.2 did not work, then I would try 1O. If that also did not go, we were already called for Corsair. So you go with this micro catheters where you think Turnpike, Corsair, this kind of, you will corkscrew and like you're doing when you're doing a CTO, and then you will open the cell through that. That definitely has worked for us.
And coming back to the extreme now, nothing else works. You tried everything possible. So what are the other options remaining, which is like rare, 9th, 10th, 11th? So one, you can do laser. Laser will definitely try to open. Then rota. We published back in 97, 98, 99, CCI paper.
That was my
Rotational
first
atherectomy of the
paper.
side branch to the stent struts. So we actually published back then. So you can ablate the metal
3.5.
with a 1.25 bar. You can do rotational atherectomy. We had 3.5 balloon ruptured. We had 3.5.
One or two balloons ruptured. And the reason also is if there is calcium in the ostium of the vessel, and we have had trouble
And
in the
four
diagonal
ruptured.
ostial calcium, you do the two
Give us
stent
a four.
technique, recrossing could be a
12.
problem.
Yep.
Then what you want to go with the circ?
But rare cases, I would say that no 4 and then do a kissing. You are done with that.
Yeah,
Yeah.
yeah.
So
Then
we actually,
finalize.
I would say probably we do one per year. Of our about 4,000 interventions we do, 700 rotational atherectomy. The one per year is the case where side branch nothing work, not even mini crush technique. It's just basically nothing going into side branch, and we end up in doing the rotational atherectomy. One case per year. Now we did try laser. Many of those cases, and laser actually many times it didn't work. Although literature was there, the side branch laser can do basically maybe just modifying the plaque and so, but did not work. So our is that once your all options have been depleted, as you just said, that we are done as Anu pointed out, a step-by-step approach. Then lastly, and I would say Corsair actually has done a tremendous job with a very pointed tip. I think maybe Turnpike, other things may have similar results, but Corsair, because the woven technology at the tip has helped to go to the side branches. Once you go to side branch, then you can start going with the same serial balloon dilatation of 1.5 and so on. But extremely case, nothing else is work. You can always do a rotational atherectomy cautiously with the 1.25 smallest bar. And using a extra support wire. You need little extra support. The floppy wire will not work in that situation. You need extra support wire. So Anu, tell us where are you and what are you doing? Yeah.
Okay, good.
As you said, actually, I mean, rota may be the last option, but else works only probably you'll consider, because there is
Yeah,
definitely very high risk of even getting stuck. I mean,
yeah,
you have
burr
three layers of
entrapment,
metals there. Yeah, burr entrapment can be a big,
big trouble.
risk.
Yeah,
Yeah. Sir,
Yeah.
one question, sir. In such a
yes.
scenario, like with the newer advents, do you think just a possibility doing an IVL in the main stent, would it actually cause some distortion of the side branch struts actually, so that it
Good.
makes it
Okay,
easier?
you go.
Yeah, so that's a good point. So question was, if the side branch had
Down.
quite a bit of calcium, and that is preventing some of the, so you cannot put IVL in the main, the side, side branch, the main, by doing this calcium. So
No,
I think the
it's okay.
same
Go
aspect,
8, both of you.
many times when we used to do a laser for those kind of purposes, that you're basically changing the lesion compliance. So that is one theoretical possibility.
Down.
Yes, I would say that is another way, that you
You
just
go.
do the IVL of the main vessel,
18, 20.
hoping to change the
Then we kiss
compliance
again,
of the
okay?
side
I should have
branch
done that.
calcium, and then you will be able to go
Okay,
in.
good. Down.
So that is
Now kiss again.
actually, we had one time
80.
discussion about few months ago on one particular case, and we about this strategy. We are not done that for this purpose, but yes,
Okay,
I
done.
mean in the native, yeah, we are done. So means there was a angulated. We did have a transmission to Brazil about 6 months ago. Very calcific angulated circ, and more angulated LED. Nothing will go. Even laser did not go. So then we did the IVL of the left main to circ. That allowed at least our Corsair to go in, changing to rota wire, and then we combine with the laser, rota, and basically in that particular case, and shockwave. So we combine all three technique in that particular case. So those are the other variations. But I would just say that once you have got to this and using the IVL and having this cost of added 3 lakh rupees on the procedure, to me, I think it's an overkill. Because your micro catheters will go, open up the little ostium. Don't even go to the rota. Rota, I would not suggest to anybody to do rota. I would definitely say, I would not suggest people to do rotation atherectomy of the side branch. But since I just wanted to answer the question because you ask it,
Okay, go.
that if required, but I would definitely be against doing that. Yeah, look at this. Looks good. You want to confirm with Ivers?
Yeah. Get the IVUS.
Yeah. So you need a
I
new
wanted
wire.
to show you. No, I know that circ wire is like gone.
Yep. Just do the LED. Yeah.
I'll do the LED only.
What
Tell
are
us.
the pressures for the kissing balloon and sizes and pressures for the kissing balloon?
So the LED we have 3.5. So I want you to. Okay. Let me see how I did it. So we did a sequential in the sense that initially we were watching the 3.5 balloon. That was a used balloon went into the LED, but the 4.0 would not go in. 4.0 would not go in. So we then dilated the left main to LED to 20 atmospheres. And then after that, when we deflated, the LED balloon went further into the LED, and then we were able to get the 4.0 from left main to sub. So 18 to 20, we did left main to LED, left main to circ, and then when we did KISS, we did 10 atmospheres.
The key is that after we always say, don't go with both of them high pressure 1820, you'll have more chance of perforation. Even if the rule of 2/3, 4 and 3.5, your vessel has to be 5, 2/3 of it. No. But what you do is individually go high pressure 1820, and then final 10 to 12 atmosphere when you do a final kissing, final inflation.
And all these are non-compliant balloons, sir?
All non-compliant.
Yeah, all non-compliant.
You
So
have
this
to
is
have
a LED now.
Yep.
Then what I'll do is I'll take the same wire and go to the circ. So
Okay.
we don't have to redo it.
All right.
Start forward.
IVUS.
Yeah, it's a new stand. Yeah, well expanded. It's coming. Yeah, I see the two layer. Well expanded. Well expanded. Now come to the left main verification. The left main. Yeah, this is the ostium, and come to the left main. So yeah, I resolve.
Good. So now I'll come out. I'll
Yeah,
go
just
with the
ostium
same
stand
wire,
into
and
place.
I'm going to go to the circ kiss key.
Should
So come.
Sir, wouldn't you do a report on the left main, sir? Yeah, that,
No.
Yeah,
What,
that's
no,
a
you
whole
see it.
question
Yeah,
was. So I think
Come here.
if you see, once you're doing
Go.
imaging, I think that will tell you anyway. But we just, to us, we have done
Go.
the pot and then do kissing. We just usually end up there. Ours will tell you
okay, start
the
forward.
uniform is not been
This is from
expanded
the
well.
circ. It's a
Yeah.
native. Come to
Even
Can you
this
bring those two
Yeah,
slides,
this is
SS,
this
quickly?
perfect. Well expanded, no malposition, no dissection. Come to the ostial circ, well expanded. Yep, area is great. Come to the left main. Nice. The elliptical shape looks area is great. Come to the
Good.
left main. All
Up to the
cover
ostium.
lesion.
Yeah.
Okay. Just AP picture last, low magnification with little
You have
medicine.
to show them two. One is that DK crush, why we have to do 2 stents. And other one is our
Low mag.
avoid
Yeah.
spot.
Sir, on the meeting, how's your assessment of ostium of LMCA? Sir?
Yeah.
Show the ostium of the LMCA, go back.
Very
Yes.
eccentric
Yeah.
opening is still.
Yeah, because
Right?
we see the outside like carcinoidal, but the area is just 1 second. It's
8.5.
yep,
Okay, ready?
like 9.
Would you, in the current scenario, require 10 in the LMCA, sir? With some
No, I think 8.5. I think once you get 8.5 and above, that is good enough.
okay.
Yeah.
Can we show those two slides?
Now, which one? Now?
Pot.
Yeah.
No, EES, sir. Pot report they were asking again.
No, but that was the kissing versus pot. Remember the pot pro trial
Extra slides.
did show, and we'll show you that there's some data on that. The only one randomized trial of the kissing versus pot, and they basically showed there that actually with the kissing you have slightly less malopposed struts, p-value of 0.08 to 0.09, and of course you have slightly lower dissection with the pot, but overall no difference in outcome. So I think whether you do a pot repot or do a kissing balloon dilatation, I think it's equally good in most of the strategies. So that's where we saw here also. It's a good lumen coming back up to the ostium, and that is completely okay. Any questions from our audience? Special?
Sir, excellent angiographic outcome and finally combined with the imaging. I'm not seeing any questions in the chat box.
Yeah, we wanted to once again show all the app slides. You'll see. Go back. Sorry.
See with the
Have
fluoro
you
time
done the
of 21 minutes.
No, sorry. Question. Yeah, what is the question? Sorry.
yeah, no, have you done the IVAS run from both vessels from the
Yeah,
LCD
yes,
to LM
yes.
and
Yeah,
LCD?
yeah.
Okay,
Yes.
okay, fine,
Both.
fine.
Yeah. Okay. Sure. Go to the slide now. Yes.
So you are asking about the apps.
Yeah,
Our
Madam,
original
these
app.
apps are quite useful. Quite
Yes.
useful for all of us. We all follow this actually. They're really, really very useful.
Thank you. So this bifurcate was our initial app. You see that we came way back in 2017. So we are upgrading that app. New app will be out in the next couple of months. Because many people want illustrations. Some people wanted animations. So bifurcate 3D was animation, which we showed. But if you want just illustrations, we have just the bifurcate and various guide wires. We have the guide wire app that is out, and that also is a big hit. A lot of people like that. The other app will be to discuss all the devices, the various devices that we use in the lab. That's called device aid. That will be out shortly. We know for OCT we have Octade. IVAS aid will be out. Various the IVAS things, and management of patients with cardiogenic shock, management of patients with hypotension, which essentially is all the mechanical circulatory support, MCS. That should be out just in the next 4 weeks.
And another one, although it's not the app, complicated website. So very big hit. We got a positive feedback. So we have shown all our experience of about 800 plus angiogram there.
Yeah.
And individually go through the process, what we found, what could have been done differently, theoretical with the videos. So really teaching point to avoid the complications.
No, remember the complication of LSD you had. We have that mentioned there. Wire perforation, our device perforation, slow flow, all these things is how to avoid when you see it, and of course, management when it happens. So all that is in the complicated on the website, which is it's a web app. Yeah.
Okay, with that note, if there's no more question from our audience, you're okay to start our case, your presentation, and I'll join you in 5 minutes. And thank you very
so
much.
much.
Thank you.
Thanks
Thank you,
for the
sir, for an
educative piece.
excellent presentation of the case. Yeah.